Hello and welcome. My name is Dr. Lizzie Smyth. I am a medical oncologist based in Cambridge, UK. Today, I'm here to speak to you about emerging data with immunotherapy in esophageal squamous cancer and the potential implications of this for clinical practice, our insights from 2021. Today, I'm going to speak to you first about 4 positive first-line trials which have changed the standard of care globally and in Asia. The first of these is CheckMate 648. CheckMate 648 was a global phase 3 randomized trial in which patients with previously untreated squamous esophageal cancer were randomized to one of 3 arms: standard of care chemotherapy alone, chemotherapy plus nivolumab, a PD-1 inhibitor, or a chemotherapy-free option with nivolumab and ipilimumab, an anti-CTLA-4 inhibitor. We can see the results of CheckMate 648 here. In terms of the nivolumab plus chemotherapy combination, first of all, we can see that there was an improved median overall survival in the all randomized group of patients of about 2 months. However, when we focus on patients who had PD-L1 expression on their tumor, we can see that that benefit is much greater, a 6-month benefit and a 46% reduction in the risk of death. That means that nivolumab plus chemotherapy will become a new standard of care globally for these patients. Moving on to the nivolumab and ipilimumab combination, you can see that median overall survival was also improved for patients treated with nivolumab and ipilimumab compared to chemotherapy. And again, we saw this small increment in terms of patients who presented PD-L1 expression on their tumor. However, when we move on to the progression-free survival, we see a different story. In the nivolumab plus chemotherapy combination, you can see that in the all randomized group, there was a small and statistically significant improvement in median progression-free survival, but this benefit is not so clinically relevant. However, looking at the PD-L1 positive patients who we know to be sensitive to immunotherapy, there is a really clinically relevant improvement in progression-free survival of more than 2 months. When we move on to the nivolumab and ipilimumab combination, we see the converse. Interestingly, response rates to nivolumab and ipilimumab were much less than those seen with chemotherapy. And in fact, when we look at the progression-free survival, we can see that chemotherapy was superior to nivolumab and ipilimumab, regardless of whether PD-L1 was expressed on the tumor. So these overall response rates and progression-free survival results mean that despite the improvements in overall survival, nivolumab and ipilimumab is less likely to be adopted as a global standard of care compared to nivolumab and chemotherapy. In terms of the toxicity of nivolumab and chemotherapy and nivolumab and ipilimumab, there was no new adverse events noted for the combination. And in fact, treatment discontinuation was quite low for patients, regardless of the arm of the study. Now I'm going to move on to ORIENT-15. ORIENT-15 was another phase 3 randomized trial, this time conducted only in Asia for patients with unresectable and metastatic esophageal squamous cancer, which was previously untreated. In ORIENT-15, patients were treated with standard of care chemotherapy plus placebo or standard of care chemotherapy plus sintilimab, which is another anti-PD-1 antibody. Here we see the results for ORIENT-15. As you can see, very similar to CheckMate 648, that in the all patient group, there was around a 3-month, very consistent improvement in overall survival for patients who had sintilimab added to their chemotherapy. In fact, interestingly, in ORIENT-15, in the PD-L1 positive population, we didn't see that same large increment in terms of overall survival that we saw in CheckMate 648. It's not really clear why this has occurred. ORIENT-15 is an Asian-only trial, but also a different PD-L1 antibody was used and a different scoring system. And this speaks to the reason of why we need systematically approached PD-L1 assessment in trials so that we can understand how these results can be interpreted globally. When we move on to the median progression-free survival in ORIENT-15, we can also see that sintilimab added in terms of progression-free survival, both for PD-L1 positive patients and for the all-comers group. Therefore, it's likely that in Asia, sintilimab will become another first-line standard of care with chemotherapy for patients with untreated squamous esophageal cancer. As expected, in terms of the toxicity, sintilimab did not add significantly to side effects for patients treated on the study. As you can see, in terms of the treatment-associated adverse events, many of these are chemotherapy-related, and we saw that discontinuation rates and serious adverse events were low overall with chemotherapy plus sintilimab. The third study, also conducted in Asia, looking at squamous esophageal cancer plus PD-1 blockade, was JUPITER-06. In JUPITER-06, again, patients with previously untreated squamous esophageal cancer were randomized to either chemotherapy plus placebo or chemotherapy plus toripalimab. Toripalimab is again a PD-1 inhibitor. And what we see in terms of the results in an interim analysis, which has been presented, is that toripalimab, when added to chemotherapy, improved overall survival for all patients by a measure of 6 months, and by the same degree in PD-L1 positive patients, again, here seen with a CPS score of 1 or greater. So it's quite likely that in future, pending final overall survival analysis of these results, that toripalimab plus chemotherapy will be another option for patients with squamous esophageal cancer. Here we can see the treatment-related adverse events in JUPITER-06. You can see in terms of the treatment adverse events that were commonly associated with treatment, most of these relate to chemotherapy. And in fact, although immune-related adverse events were clearly more common in patients treated with toripalimab, the treatment discontinuation was very low at less than 3% of patients overall. The final study, which was also recruited in Asia, treating patients with squamous esophageal cancer, was the ESCORT-1 study. So ESCORT-1 randomized patients with previously untreated advanced squamous esophageal cancer to either chemotherapy plus placebo or chemotherapy plus camrelizumab, which is an anti-PD-1 antibody. The results of ESCORT-1 are shown here. As you can see, adding camrelizumab to chemotherapy statistically and clinically meaningfully improved overall survival in the treatment population by approximately 3 months, and also provided a meaningful benefit in terms of progression-free survival. Adding camrelizumab to chemotherapy did slightly increase the rates of serious adverse events, but these remained low overall, and treatment discontinuation was low in both arms of the trial. Therefore, adding camrelizumab to chemotherapy provides another option for anti-PD-1 inhibition plus chemotherapy in squamous esophageal cancer. I'm going to move now from these big group of first-line trials into the second-line space. So the RATIONALE 302 was a very important study in the second-line setting for squamous esophageal cancer. RATIONALE 302 was a global phase 3 randomized trial in which patients with previously treated squamous esophageal cancer were randomized to either investigator's choice of chemotherapy or tislelizumab, which is an anti-PD-1 antibody. As you can see here, the results of RATIONALE 302 support the use of tislelizumab as a second-line treatment in previously treated squamous esophageal cancer. In the all-comer population, there was a 2.5-month benefit in terms of median overall survival, and this benefit was incremented in patients who were PD-L1 positive. Importantly, in RATIONALE 302, patients who were treated with tislelizumab had more than double the response rate of patients treated with chemotherapy. Response rates were 10% versus 20%, respectively. So this certainly establishes tislelizumab as a new standard of care in the second-line setting for previously treated esophageal squamous cancers. And importantly, when we look at the toxicity of anti-PD-1 inhibition with tislelizumab compared to chemotherapy, in fact, chemotherapy was certainly associated with more treatment-related adverse events and more treatment discontinuation compared to anti-PD-1 therapy. So, pending regulatory approval, tislelizumab is an excellent choice for patients in the second-line setting with squamous esophageal cancer. The CheckMate 577 study was a global phase 3 randomized trial in which patients who were at high risk of recurrence following trimodality therapy were randomized to either placebo or nivolumab for a year after surgery. You can see from the results here of CheckMate 577 that patients who were treated with nivolumab had much better disease-free survival compared to patients who were treated with placebo. In fact, patients who were treated with nivolumab had double the disease-free survival. This was improved from 11 months to 22 months for nivolumab-treated patients. The best results were shown in patients who had esophageal cancer. We've been speaking about PD-L1 expression in CheckMate 577 when PD-L1 was examined on the tumor using TPS score. This did not influence the benefit from nivolumab. However, in a post-hoc analysis, when we looked at PD-L1 using CPS score, both on tumor and immune cells, this suggested that the benefit for nivolumab was limited to patients who expressed PD-L1 at a CPS score of 5 or greater. However, because this is a post-hoc analysis and prone to bias, we don't use PD-L1 to select patients for adjuvant nivolumab. Finally, when we move on to treating patients post-esophagectomy, we know that this is a fragile patient population, as esophagectomy has a significant impact on patient well-being. And really encouragingly, patients treated with nivolumab did not have really any significant increase in serious adverse events or treatment discontinuation when treated with nivolumab for a year, and quality of life was not adversely affected. So certainly this supports the use of adjuvant immunotherapy with nivolumab following trimodality therapy for patients who are at high risk of recurrence. So in summary today, we've reviewed the new developments in immune checkpoint inhibition for patients with squamous esophageal cancer emergent in 2021. We have several new first-line options for patients with untreated squamous esophageal cancer. This includes the PD-L1 antibodies nivolumab plus chemotherapy, sintilimab plus chemotherapy, toripalimab plus chemotherapy, and camrelizumab plus chemotherapy. In previously treated patients, single-agent tislelizumab is a new standard of care for patients with advanced squamous esophageal cancer. And finally, for patients post-trimodality therapy, chemoradiotherapy and surgery who are at high risk of tumor recurrence due to residual tumor in their resection specimen, a year of adjuvant nivolumab is a new treatment option. Thank you very much. Hello, everybody. Thanks for joining us today. My name is Dr. Lizzie Smyth. I'm a GI oncologist from Cambridge, UK. Welcome to the second part of the touchTALKS series. Today, I will be discussing developments in immunotherapy for patients with squamous esophageal cancer from the ASCO 2022 and ESMO World GI meetings. So, over the past year, we have developed a number of different treatments for patients with advanced squamous esophageal cancer. Many patients, usually dependent on their PD-L1 score, are receiving treatment with chemotherapy and an anti-PD-1 antibody. PD-L1 can be assessed on the tumor using a TPS score or on the tumor and infiltrating immune cells using a CPS score. If a patient has a tumor with a TPS score of 1 or greater, chemotherapy plus nivolumab is an option. If a patient has a PD-L1 score CPS of 10 or greater, chemotherapy plus pembrolizumab is an option. We also have a new chemotherapy-free approach for patients who have tumors with a TPS score of 1 or greater, that's nivolumab and ipilimumab. So altogether, around 50% of patients express PD-L1 on their tumors, but for patients who do not express PD-L1, platinum-based chemotherapy is still a good treatment option. The use of immunotherapy for patients with squamous esophageal cancer is based on the results of 2 big randomized trials which were recently presented. These are CheckMate 648 and Keynote 590. CheckMate 648 looked at the combination of nivolumab with chemotherapy or nivolumab and ipilimumab and compared this to chemotherapy alone. Keynote 590 looked at the combination of chemotherapy and pembrolizumab and compared this to chemotherapy alone. Both of these were global trials, however, recruited a majority of patients in Asia as squamous esophageal cancer is very common in that region. CheckMate 648 examined patients with only squamous esophageal cancer, whereas Keynote 590 included patients with adenocarcinoma of the esophagus too, although squamous cancers did predominate. We've seen at ASCO 22 a recent update of the results of CheckMate 648. This update included overall survival by baseline PD-L1 status, progression-free survival 2, and duration of response analyses, as well as safety updates. First, we'll look at progression-free survival 2. Progression-free survival 2 means the time from randomization on the trial to progression on second-line treatment or death from any cause. This is really asking the question about whether immunotherapy could impact on subsequent treatments after progression. What we see in CheckMate 648 is that patients treated with chemotherapy alone had a PFS2 of around 8 months. Patients treated with nivolumab and ipilimumab in first line had progression-free survival 2 of around 11 months. What this implies is that the use of immunotherapy in first line could have extended benefits even into second line. That's because the progression-free survival 1 for patients treated with nivolumab and ipilimumab in CheckMate 648 was around 2.5 months greater than chemotherapy. So this is implying that there could be an extended benefit to immune checkpoint inhibition in the first-line setting. Moving on to the results of nivolumab and ipilimumab, you can see that there is a 2-month survival benefit in progression-free survival 2. And this is interesting because progression-free survival 1 for that combination was better for chemotherapy. This result may be because patients treated with nivolumab and ipilimumab first line did not have chemotherapy before second line. However, taken together, these results do suggest that early use of immunotherapy is helpful for patients. Moving on to the median duration of response data, which was presented from CheckMate 648. Patients who were treated with chemotherapy who had a response had a median duration of response of around 7 months. For patients treated with nivolumab and chemotherapy, this was 8 months. However, the longest duration of response was for patients treated without chemotherapy who received nivolumab and ipilimumab at 11 months, although it should be noted that fewer patients did respond to that regimen. The longevity of benefit for patients treated with chemotherapy can be seen in the proportion of patients who have not progressed at 1 year. For patients treated with chemotherapy who respond, those who haven't progressed at 1 year are 25% or less than a quarter. For nivolumab and chemotherapy, this is just under 40%, but for nivolumab and ipilimumab, this is almost half of patients, suggesting that the use of anti-CTLA-4 is associated with maximum duration of benefit. Moving away now from CheckMate 648 onto the study RATIONALE 306. RATIONALE 306 was an international phase 3 randomized trial in which patients with squamous esophageal cancer previously untreated were randomized to chemotherapy plus placebo or chemotherapy plus tislelizumab. Tislelizumab is an anti-PD-1 antibody. What's interesting about RATIONALE 306 is that various different chemotherapy backbones were used, including cisplatin and oxaliplatin, as well as platinum taxane combinations and platinum 5-FU. This compares differently to the chemotherapy used in the previous studies, which was cisplatin and 5-FU based. These are the take-home results of RATIONALE 306 as presented at ESMO World GI. You can see that there's a 34% reduction in the risk of death and a 6-month improvement in median overall survival for patients treated with tislelizumab. This means that tislelizumab may be adopted as another global standard of care with chemotherapy for patients with advanced squamous esophageal cancer. As I've mentioned, PD-L1 status has tended to be the driver of outcome for patients with upper GI cancers treated with anti-PD-1 therapy. Here we can see the breakdown of the RATIONALE 306 results according to PD-L1 status. For patients who were PD-L1 high or had a PD-L1 score of more than 10%, the reduction in the risk of death was around 38%. For patients who had lower scores of PD-L1, less than 10%, the magnitude of benefit was less. The reduction in the risk of death was 28%. However, there was still a median overall improvement in survival of around 6 months, indicating that tislelizumab may be an appropriate treatment for patients with high and lower PD-L1 scores, although we should probably qualify that by looking at the outcomes for patients who do not express any PD-L1, which has not yet been demonstrated. Of course, when we adopt new standards of care, we need to consider toxicity. These are the safety results from RATIONALE 306. We can see that the addition of tislelizumab to chemotherapy did not exacerbate any chemotherapy-associated side effects. However, with anti-PD-1, we need to be aware of and manage any immune-related adverse events which do occur. Moving on from the first line to the second line setting, we know that many patients, probably around 50%, will go on to receive immune checkpoint inhibitors in first line now, based on PD-L1 status. However, for patients who do not receive immune checkpoint inhibitors in first line, this is also an option in second line and is done in a biomarker unselected manner. This is based on the results of many clinical trials, including ATTRACTION-3, KEYNOTE-181, ESCORT, and RATIONALE 302. Often, we are asked whether the outcomes for patients in the real world are the same as those observed in clinical trials. And an important study presented at ASCO has demonstrated this with previously treated squamous esophageal cancer patients. The investigators looked at the outcomes of patients treated with anti-PD-1 therapy in the second line setting for squamous esophageal cancer. Most patients in the study were treated with nivolumab or pembrolizumab, which are some of the current standards of care. The results show that the time on treatment for most patients was between 2 and 3 months, what is similar to what is seen in the clinical trials. And again, really encouragingly, the median overall survival was about 10 months, which is exactly replicates what was seen in the second line registration studies. So it's very reassuring to see the results of the registration studies validated in a real world data set. Finally, quality of life is really important for patients with esophageal cancer, in particular because this is a disease that causes a lot of symptoms and morbidity. The RATIONALE 302 health-related quality of life results were presented at ASCO 2022. RATIONALE 302 was a global phase 3 randomized trial which assessed tislelizumab and compared it to chemotherapy in patients with previously treated squamous esophageal cancer. A survival benefit was demonstrated for tislelizumab, meaning that this was adopted as a standard of care in certain countries. In terms of the quality of life data which were presented from RATIONALE 302, patients treated with tislelizumab tended to maintain their quality of life and had better physical functioning compared to patients treated with chemotherapy who unfortunately suffered a deterioration. Indeed, patients treated with tislelizumab had fewer esophageal cancer-related symptoms, including dysphagia and reflux. Taken together with the overall survival results of RATIONALE 302, this means that tislelizumab is a good option for patients with previously treated squamous esophageal cancer. So, in summary today, we've seen some exciting results for patients with esophageal squamous cancer. In the first line setting, we've seen the results of RATIONALE 306 presented at ESMO World GI, which established tislelizumab plus chemotherapy as a new standard of care for untreated advanced squamous esophageal cancer. In the second line setting, we see both real-world data and health-related quality of life results which support the use of second-line immune checkpoint inhibitors in immune checkpoint naive patients. Thank you for joining me today, and see you next time.